Due to working on the front line of the COVID-19 pandemic, Dr. Malata was unable to record this presentation. She gave permission to the conference organizers to dictate her slides on her behalf. We are looking forward to having her join us live on August 8th for the conference. Decolonizing Global Health Education, slides by Professor Adres Malata. We're first going to start with the content overview of this lecture. We will start with an introduction of decolonizing global health education. This will then be followed by the 5 big causes of unequal representation. We will then speak about gaps between high-income countries and low and middle-income countries. Then we will move on to supporting change, mitigating the unequal representation in global health. We will then speak about emerging issues such as COVID-19 and future pandemics, which will allow a time to reflect on global health education. We will finish with a conclusion. Introduction. COVID-19 has energized the debate about global health worldwide, and it's making everyone ask questions such as, is it truly about equity and justice? Decolonizing global health aims to question the status quo in global health education and research. Efforts to decolonize global health are on the rise as academics, researchers, health practitioners, and health activists are striving to minimize power imbalances that are seen in the global health practice today. Introduction. Global health education is a multidimensional concept, and there have been calls to decolonize and relook at assumptions and practices. It is obvious that knowledge generated in high-income countries defines practices and policies in low and middle-income countries, and this can sometimes cause solutions to be seen from a lens not from the country it is implemented in. A quote from Melinda Gates says, "If you want to see things happen at a global level, start at the village level. Give women the tools and education, and they will drive the change," highlighting the importance of local input in decision-making. Global health entails partnerships between institutions in low and middle income countries that were previously colonized by high income countries. Education and global health faces colonizations in various ways. For example, in research, such as who sets the research agenda, capacity building efforts, and who carries out and benefits from clinical trials. Secondly, in literature, in journals and books, in access and who is publishing. Next, in teaching and learning, such as the curricula and teaching models. And finally, in innovation and technology, such as internet access and software applications. The big 5 causes of unequal representation. First is inadequate human resources. Second is the economy, such as inadequate financial resources. Third is technical challenges, followed by collaboration limitations, and political, environment, and cultural factors. Diving deeper into the big 5 causes of unequal representation. First is weak economies in low and middle income countries. As opposed to high income countries, LMICs have inadequate financial resources for all sectors, including health and education. Unequal distribution of income inequalities furthers this. Inability to purchase state-of-the-art equipment and technology in LMICs limits research to traditional methods. Ultimately, everything revolves around the economy. Second is inadequate human resources for health. This includes limited local expertise, quality versus quantity, and education, recruitment, and retention of a skilled workforce. This begs the question, how can we address this skills gap, which has been a question that has been heightened during the COVID-19 pandemic worldwide? Third is the political, environmental, and cultural factors. This includes lack of political will, cultural and ethical values, inadequate mentorship, especially for reading and writing culture, and lack of sustainable markets in low and middle income countries. Ultimately, transformative leadership and conducive environment is required. Fourth is innovation and technological challenges. Infrastructure and technology, including ICT, lack of investment in innovation, inability for experts and institutions in LMICs to purchase state-of-the-art equipment, and an inability to afford licenses of the same gold standard software, leading to low-quality research outputs. Ultimately, there is a need for institutional science, technology, and innovative functions. Fifth is collaboration limitations. Institutions from high-income countries like to collaborate with high-ranking institutions. Hence, this limits collaborations with institutions from low and middle-income countries, which mostly rank low due to the ranking criteria and limited resources. This includes South-North relationships as well as South-South relationships. Before we move into decolonizing global health education, we want to speak a little bit about global health gaps between high-income countries and low- and middle-income countries that were there before COVID-19. So first, this includes communicable and non-communicable diseases, where 80% of disease occurs in low and middle-income countries, while 20% of non-communicative disease occurs in high-income countries. Secondly, health experts. Greater than 80% are located in high-income countries, and less than 20% are located in low and middle income countries. And third is mortality. Higher mortality rates and lower life expectancy in low and middle income countries as compared to high income countries. Next, we have a few graphs to illustrate these points. First is the global healthcare worker crisis. From this graph, you can see that there is a mismatch between the percent of global workforce and the percent of global burden of disease, with the larger percent of the global workforce not representing the larger percent of the global burden of disease. Next, we have a map of the atlas of the healthcare workforce. As you can see in this map, the darker orange shows a critical shortage in healthcare workers, while the lighter orange shows countries that are without a critical shortage in healthcare workers. And finally, we have a graph that links survival with the density of healthcare workers. And as you can see, as the density of healthcare workers increases, infant, child, and maternal survival increases. So now that we've talked about the importance of a skilled health staff and workforce, we're going to talk a little bit more about decolonizing global health education. So first of all, decolonizing the education curriculum allows for enhancing equity, more inclusiveness, the ability to question some viewpoints, including some missing information and asking uncomfortable questions, and making all of this more accessible. Second, global health education addresses health issues directly or indirectly that are caused by transnational factors. And third, decolonizing global health education means reducing health inequities and disparities between and among developed and developing countries. Next, we're going to talk about how can we achieve decolonization. There are many facets of decolonization that are equally important to achieve this goal or to work towards making this goal. First is leadership and representative leadership, so that there's representative leadership on the table making the decisions that impact. Second is a critical review on teaching and learning practices. Third is using languages beyond English to make a more inclusive environment. Fourth is data management. Fifth is mentorship programs, which research processes, including dissemination of results writing and presentation skills. Next is activism and lobbying for support in low and middle income countries with local agendas being represented. And finally is collaborations, both North and South and the South-South, but with a win-win situation, rethinking partnerships and what partnerships really mean. Emerging issues due to the COVID-19 pandemic allow for reflection in decolonizing global health. This includes changes in disease burden humbling high-income countries with great economies, inadequate human and material resources, including infrastructure to manage the pandemic in low and middle income countries and in high income countries alike, politicians downplaying the effects of COVID-19, which causes a lack of civic education. Next is research deficiencies such as vaccines, an exposure of inequities, and a digital divide. Finally, the role of global health during this pandemic has been obscure. We want to thank you for your attention. We are really looking forward to having Dr. Malata for the conference on August 8th in the Q&A, and are really looking forward to your questions and a great discussion. Thank you again.